Good morning, everyone. Welcome to the RCI GDAS webinar titled Strategies for Managing Problem Behaviors by Mrs. Cindy Holloway. Before we get started, let's cover a few conference details. If you have a question during the conference, we ask that you type in the question. All questions will be answered at the end of the conference. Also, if you are at your own computer station, a post-test survey will pop up at the end of the webinar. There will be 10 questions about the webinar and personal information questions such as name and email address that will enable me to send you your certificate. If you are not at your own computer, copy down the link that is posted on the last slide of this presentation. Use the link at your own computer to complete the post-test. Certificates will be sent within 1 week after the closing of the test. I ask that you please complete this test by August 9th to receive your certificate. We are now ready to begin. Welcome, Mrs. Cindy Holloway.
Good morning. I want to thank you for giving me this opportunity to share my personal and professional experience with Alzheimer's and related dementia behaviors. I'm going to give you a little bit of background on my experience, and the reason I do this is so you will know the extent of problem solving that I've had with behaviors. For 15 years, I served as director of a secure dementia-specific facility that cared for 30 people in early, middle, and late stages of the disease. In addition to the residential care, the facility also opened its doors to the community by providing adult daycare services and also care consultation for families on the waiting list, as well as those who were not even considering placement. So we covered just about all of South Georgia. I'm now working with the Rosalind Carter Institute for Caregivers as program manager of the Georgia Care Consultation Program. This program is also assisting families in problem-solving behaviors as well, in addition to other things. While I was at the residential facility, my office was located right within the building, and I had an open-door policy, of course, to all residents, family members, and staff. On a personal level, I also assisted my mother in caring for my father, who lived with Parkinson's disease as well as vascular dementia. So the strategies that I'm sharing with you have been tested over the last 15-plus years and have proven to be very workable. Today we're going to be building on the Alzheimer's one-on-one presentation by Amanda Hughes. She presented in April 27th of this year. And if you haven't had the opportunity to see this presentation, I want to encourage you to go to the RCI website where it's archived under the Resource tab, and then go to the GDAS RCI Evidence-Based Dementia-Capable Trainings, and it'll have all of these webinars archived there. All right, I'm going to move on to...
Mrs. Holloway, it seems that some people are having problems hearing you. Perhaps you could take it off the speaker and hold it up.
Okay. Is that better?
It's better on my end.
All right. What we want to learn today is the who, what, when, and where of dementia behavior problem solving. How to assess whether or not the behavior warrants an intervention. And then also what specific behaviors are trying to tell us. What triggers may be causing the challenging behavior, and then how to minimize those triggers. And this is our problem-solving outline. Let's just review some of these behaviors. In numerous studies, caregivers report that challenging behaviors is one of the biggest stressors that they face. The inability to solve these behaviors leads oftentimes to placement in long-term care facilities. So assisting them with this problem-solving process may delay or eliminate a placement. The first one we're going to look at is agitation, and then also aggression. Aggression is a more aggressive form of agitation. Anxiety, and this is the type of anxiety that is uncontrolled. They're not able to reason themselves out of the anxious situation or anxious thoughts. The next one is catastrophic reactions, and this is a term that's used for a situation that has become so overwhelming that a care receiver just simply shuts down. Increased confusion. This accounts for the onset of a lot of the behaviors that are listed here. Delusions is a firm belief in something that's not real. Hallucinations is seeing, hearing, or smelling something that isn't real. It's very real to them, though. Hoarding. This is hoarding everything from food and used Kleenexes, just anything. Inappropriate sexual behaviors. The disease can cause a change in the libido and cause care receivers to do things that they normally wouldn't do. Inappropriate toileting. I don't know if you have heard this on a list of behaviors before, but this is something that's very common. This is toileting someplace other than the bathroom or in an incontinence product. Paranoia, which is extreme suspicious behavior. Repetitive behaviors, and these repetitive behaviors can be either verbal or physical. Sleep disturbances, that's getting their days and nights mixed up. And then sundowning, which is an increased confusion in the late afternoon. There's been a lot of theories and studies done concerning sundowning, but with my experience, all the evidence that I see leads to the fact that it's just a shift in the time of day. It's the time of day that the husband should be coming home from work and the children should be there doing their homework and they should be preparing their supper. Wandering, and this is aimlessly moving about or actively seeking exit.
Mrs. Holloway, it seems that some people are still having a little difficulty hearing you. Could you just speak a little louder, please?
Oh, okay. I sure will.
Thank you.
Our next slide here is defining the problem behavior. This is the first step in this process. We're going to dissect a behavior situation using our problem-solving technique. Caregivers are often just overwhelmed by challenging behavior, so we're going to break it down into steps. What we're going to do is a behavior situation that I actually experienced in consulting with a family. So I wanted to give you an outline of the process here with a real situation. We have a caregiver whose husband is driving her crazy. She isn't specific as to what is driving her crazy, so in questioning further, she tells me that my husband's driving me crazy when he repeats da 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 da. And it's really getting on her nerves. And this is defining the problem in a more specific manner. Then the next step would be to keep a diary of events concerning that behavior. And this would help identify a pattern, the who, when, or where that defines that behavior. It doesn't have to be more than just a brief note, but thorough enough to cover those questions. Who was involved in the situation? What happened in detail? When did it happen? What time of the day was it? And then where did it happen? And then what we want to do as well is to question whether we need to intervene or not in this problem. Questions you would need to ask yourself is, can the care receiver control their behavior? Does the behavior pose a threat to his safety or the safety of others? And then, does the behavior significantly violate the rights of others? Okay. And those are the questions that we're going to ask right there when keeping a diary. In our scenario, we have got Mr. Jones, who is an 83-year-old who was diagnosed with Alzheimer's 4 years ago. Mrs. Jones reports that he started to become verbally repetitive. He's repeating this da-da-da-da-da-da-da-da, and it's literally driving her crazy. I asked her to document the who, what, and when, and where that went with this. So we're going to go through that. Who was involved? Mrs. Jones reports that it happened whenever she had a visitor in her home or when she was talking on the telephone. And what happened, she says that when her friend comes over for coffee, Mrs. Jones would set Mr. Jones up in the living room with his stamp collection or their picture album, which he always enjoyed spending time with. And then she and her friend would visit at the kitchen table. While they're visiting, it wouldn't be long before Mr. Jones would start saying his da-da-da-da-da in a soft monotone, but then it just kept getting louder and louder and louder. And then he also did this when the phone rang. When did it happen? It only happens when she has a friend come over for a visit or, again, any time that she's on the telephone. Where did it happen? It happened within the home. Now that the behavior has been documented, we want to ask that realistic question there as to whether this is a behavior that can be changed, whether it's realistic to expect Mr. Jones to change his behavior, or will the caregiver need to make an adjustment in their reaction to the behavior? In other words, whose problem is it? The question is to intervene or not to intervene. In working with families, I'm often asked if the behavior is a result of the disease or if it's due to a personality trait such as stubbornness or stinginess. My reply is always, I don't know, and we never will know. But what I do know is that it's a lot less stressful and much more productive to assume that all behaviors are beyond the care receiver's control, Then they can move on to finding a solution or discover a way to live with that behavior. Okay? In our example, Mr. Jones, with him, would it be reasonable to expect him to control his repetitive monotone? Mrs. Jones knows that he's never been fond of company in the home, and especially her female friends, but would tolerate them before developing Alzheimer's. And he always hated the time that she spent chatting on the phone. At this stage of the disease, she isn't able to reason with him, and it appears that he's lost some of his social graces and also some impulse control. So the answer is no. He can't control or be held responsible for this behavior. As an aside, I wouldn't discourage a caregiver from trying to reason with a care receiver one time, while keeping in mind that one of the symptoms of dementia is losing that ability to reason. But if the strategy doesn't work immediately, then the caregiver needs to move on. To try to continue to reason with the person may lead to some very negative consequences. In other words, the other questions we're going to ask, of course, and whether to intervene or not, as we said, was Does the behavior pose a threat to the health or safety of themselves or others? And then does the behavior significantly violate the rights of others? Okay. Now we're going to move on. Now that we've documented the behavior and decided that there is a need to address it, let's look at what could be triggering that behavior. In this case, the trigger is pretty evident. Mrs. Jones is female company, and when she's on the telephone. Other triggers are not often as obvious. And here are some trigger categories that we'll explore in a little bit more detail later on. The trigger in our scenario is the environment. Now let's explore possible solutions to this situation or how to minimize the trigger. I've learned in problem-solving training that brainstorming can be very effective if we write down all possible solutions to a problem behavior, even if they sound silly to us. In dementia care, the silly solutions may turn out to be very practical after all, and I encourage you to enlist friends and family in these brainstorming sessions. So let's list some possibilities to our scenario. One would be Mrs. Jones can stop having coffee with her friends. Another is that she can stop talking on the telephone. She could have coffee at her friend's house. She could investigate an adult daycare program for Mr. Jones and have that time to socialize. She could have one of her friends come over to visit and engage him as she's visiting with her friends. Mrs. Jones could ask one of her children to take him for a ride while she spends time with her friends. And she can visit with her friends while he's taking a nap. That's another possibility. She could give him a special food treat while visiting. And then lastly, she wrote down she could talk to his doctor about increasing his anxiety medication. Now, let's review all of those possible solutions for feasibility. You would eliminate solutions that just didn't work for that caregiver. Again, enlist family and friends in this process as well. And then I would encourage them not to be afraid to try something new or unconventional. And then be prepared to change strategies later on, because one solution may become the problem at another point in time down the road. So in looking at Mrs. Jones's list, let's review them for the feasibility. Having Mrs. Jones stop having coffee with her friends or not talking on the telephone, that's not really one that we want to use. Mrs. Jones needs her socialization just as well as anyone else would. Having coffee at a friend's house, that doesn't really work for her as well, because she doesn't feel comfortable leaving him at home. It's no longer safe for him to be left alone. She had investigated an adult daycare program in her community, but sadly there wasn't one for his stage of the disease. She had thought about inviting friends over, some of his friends, to visit with him, but his friends had kind of fell by the wayside as the disease progressed, or many of them had passed away. She talked to her children about coming and staying with him or taking him out for a ride, but they all worked during the weekdays, and it just wasn't possible for that to happen. So her daughter said that she would be available on Saturdays to take him for a ride. Visiting while he's napping, that was another possibility. But Mrs. Jones needs an opportunity to rest herself, so she takes a nap when he does. through being very observant, she discovered that when he's eating, his mouth is too busy to go da-da-da-da-da. So the food treat is one possibility. Mrs. Jones felt that because his behavior wasn't harming himself or others, it was only very annoying to her, that it didn't warrant talking to the physician about a medication increase. So out of that list, she came up with two possible solutions. One was to visit with her friends on Saturday when her daughter was available to take him for a ride. Another was to feed him while she visits or on the telephone. And in the end, she chose to use both of those solutions. Her daughter was available at times, and that worked out well. But, of course, her daughter wasn't going to be there when she was on the telephone. So she experimented with some quick treats that would keep him occupied and discovered that a Tootsie Roll Pop was an ideal solution. She could give him one very quickly, and it provided some entertainment for him and kept his mouth busy while she was visiting. Okay. All right, now let's take a closer look at those triggers. The categories for them is the environment. Another is the care receiver's physical condition. The third is the complexity of a task that they're trying to do. And then the other is the caregiver's body language or attitude. In taking a closer look at the environmental triggers, the first one is loud noises or background noises. As we know, loud noises can be very startling. Background noise can compete for a care receiver's attention. The radio or television may be too distracting for someone who has to concentrate very hard on the simplest task. In my experience, I observed people actually talking to the television as though the person was in the room. Large crowds of people oftentimes can be very overstimulating for someone with dementia. Socialization is very important, but there comes a time when attending, say, a football game may be just, as I said, way overstimulating. Strange or indifferent environment. And I observed this trigger in my father. On a trip to visit his doctor, I took him home by a different route when he was accustomed to going just one way, and discovered that this simple change made him very anxious. Being too hot or cold and not being able to verbalize their feelings can cause an adverse reaction. And then too restrictive of an environment. If a care receiver pulls everything out of the chest of drawers while sundowning, rather than denying them this activity by locking everything away, allowing them to have one or two drawers to rummage through each day may be enough. Understimulation. Providing interest and stage-appropriate activities balanced with periods of rest during the day. Please keep in mind that even getting up, bathing, dressing, or eating breakfast can wear a person out if they suffer with dementia. Their mind has to work very hard to complete these very simple tasks. So allow them a period of rest before moving on to another activity. The next category of triggers is the physical. Infections and urinary tract infections I put them at the top of the list there because Alzheimer's and other dementias not only affect the memory, but it also compromises the immune system. This makes someone more prone to getting infections, and especially urinary tract infections. And these can be very insidious. So if your care receiver shows symptoms of increased confusion or agitation or even develops an unsteady gait, then the first thing you should do is investigate as to if they have an infection or a UTI. Oftentimes a physician will put a care receiver on a continuous low dose of antibiotic due to frequent occurrences of these infections. The next one is constipation. Decreased fluid intake and decreased mobility can lead to constipation, which can lead to increased confusion and agitation. Constipation can be deadly to a weak elderly person, so a caregiver will need to be diligent in monitoring for this condition. Adverse drug reactions or drug interactions. This is very common, also due to the fact that the elderly is not able to process medications as efficiently as a younger person, and so this is something to be aware of as well and investigate. Pain. Signs and symptoms that a person may be in pain when they're not able to verbalize this would be increased blood pressure or pulse, grimacing, guarding a body part, pacing. And if you suspect that your care receiver is in pain, then consult with their doctor. The next one is hunger or thirst. Again, I'm going to use my daddy as an example on this. If you ask him if he was hungry or thirsty, his response would invariably be, "No, honey, now don't you trouble yourself with fixing me anything." But if you handed him a glass of cold water, he would drink it down and say, "Thank you, honey, that was mighty refreshing." So asking them if they're hungry or thirsty, oftentimes you'll get a negative response. Simply hand them the food or hand them a glass of water. Needing to be toileted is a physical trigger. Again, if you don't have that ability to make their needs known, then putting a person on a routine toileting schedule can often cut down on agitation due to a full bladder. Complexity triggers. Now, this is being asked to perform a function that they can no longer accomplish. And I'm going to tell you a little story, again, from my days in the Alzheimer's facility. I had a lovely woman that was an accomplished pianist, and we had a piano there in the center. And as she was wandering around through the day, then she would sit down at the piano and just start playing. And we enjoyed that, and she enjoyed it. As the disease progressed, then she sat down less and less at the piano, and she looked more confused. She got to the point where she didn't really initiate playing any longer. So what we did is we would take her to the piano, and we would hit a few notes. And those notes would trigger her brain into remembering music, and she would play. And that's how we kept her active with something that she really found pleasurable. If we had sat her down and said, "Miss Smith, I want you to play the piano," then she can just sit there and not know how to start and have a confused look on her face. If we had pursued it and pushed it, then it may have caused some agitation. So these complexity triggers oftentimes will start off with creating that agitation and that confusion. The thing to do would be to cue a person when you're getting them involved in an activity if they look like they simply don't know how to start. And cueing is simply starting the activity for them or mimicking the activity, such as we did, playing a few notes on the piano. The next category is caregiver triggers. The first one that I have on there is the caregiver's body language. You and I don't respond well to somebody who is tense and has their arms crossed in front of them, has this scowl on their face, a caregiver can get a lot more accomplished with a more relaxed, open, welcoming body language. Instead of asking your husband if he wants to take a bath, invariably you'll get a no answer. Caregiver walking up to him, holding their hand out, like with a come with me gesture, and with a big smile on their face, 9 times out of 10, they'll grab that hand and get up and go with you. So a caregiver's body language is very important. The next is a caregiver's attitude. If the attitude of the caregiver is, this is the worst part of my day, when they try to give someone a bath, then that attitude would be conveyed. Having the attitude that we're going to take this step by step, we're going to make it a pleasant experience, and many of my staff will use music during a bathing experience. They would sing to them some of their favorite hymns. They would talk to them about their accomplishments in life, and that was a distraction to them while they were doing something they really didn't want to do, which was to bathe. So a caregiver's attitude and interaction with the care receiver is so very important. Disagreeing, reasoning, or correcting, of course, would be inappropriate. That was one of the things that my staff was trained to do, was never to disagree with a resident. If they said the sky was purple, we said, oh, that's a beautiful shade of purple. Or if they said they were going home this afternoon and we knew that they weren't, we'd say, well, I'm so glad you're going to be with us until then, and then distract them into an activity. Reasoning, again, reasoning when they are set in their ways, that you need to do something because, that usually does not work. As I said, reasoning one time to see if it does trigger a response with them, a positive response, is appropriate, but after that, no longer. Correcting someone, again, that's inappropriate as well. I want to share with you something that I taught every new staff member, a tool that they would use, and that's what I called relationship orientation with each one of the caregivers. Anytime during the day, especially when they woke up for a nap, or we were changing from one activity to another, or during those sundowning hours, they would look like deer caught in the headlights, if you know that expression. They just had this wide-eyed look. I don't know where I am. I don't know what I'm doing here. I don't know who you are. And we would always respond in this way. First off, we would call them by name. Hi, Mr. Jones. I'm so glad to see you. How you doing today? The next thing would to say, tell them that they are where they're supposed to be. And you can do it in the fashion like, boy, I'm so glad you came into my office to see me, and I'm so glad that you live here with us. The next thing would be to tell them that their family knows where they're at. This is so very, very important. And using family names. Mr. Jones, you know, David and Joyce are both at work right now, and they know that you're here with us and that you're safe with us. And, again, we're so glad you're here. So you're telling them that you know who they are, they're where they're supposed to be, their family knows where they are, you're cueing them into the fact that they're safe there. And then the next thing I would always add would be, well, you know, let's just sit down here and chat for a little bit. We're going to have dinner in just about 30 minutes. because that's always important, is to know where the next meal is, where it's coming from, how long it will be. And so using this technique, it's relieved a lot of anxiety in people that are suffering from dementia. I want to speak a little bit about medications, and I'm not going to dive too deeply into this. Medications is something that should be used as a last resort when distraction or relationship orientation doesn't work. When any of these other things are tried in problem solving with behaviors, then that, again, is a last resort. In my experience, behaviors and especially the agitation and aggression behaviors are more common in men than it is in women, and that the medications oftentimes are used more often with them. It's important to have the physician reevaluate the medication dosage. If a man had a catastrophic reaction and it required a medication, a new medication at a dose that took care of the situation, then at a later time when things have stabilized, then it's a good idea to speak to the physician about reducing that dosage and seeing if that would be all that it needed. And again, reevaluate the need for the medication. As the disease progresses, medications for anxiety, for behaviors such as wandering to the point that they've exhausted themselves, these things may not be necessary any longer. If you are on a medication for an anxiety because you're in the early stages of the disease and you know that you are dealing with this and you know that you're forgetting things that are very important in your life, then the need is there. But as the disease progresses, quite often someone dealing with the disease has forgotten what they have forgot, and so they may not need that medication any longer. And then lastly, I want to look at side effects of medication. We're not going to dive into that in detail again, but I want to say that there are no perfect medications. And medications should be used as a last resort because there are side effects there that are negative. As a caregiver, you would have to balance out the benefit of the medication versus the negative benefit of the side effect. So this is very important. And then lastly, I wanted to put on there a caregiver proverb: those who do not bend will break. It's important to be flexible in dealing with these behaviors. One thing that works today may not work tomorrow, but yet it may work day after tomorrow. It's a challenge to all caregivers in dealing with this. A solution may have to be adapted at another time. Having a time to breathe when a problem is solved is a great break for the caregiver, and so they need to rejoice in that, and then move on. I want to leave time for some questions, and if you would please type your questions in. I'm sorry you had trouble hearing earlier in the presentation, and I'll be happy to answer any questions. We've got plenty of time to do that.
Yes, thank you, Mrs. Holloway. Also, I just moved the slide over that you can see the link to the post-test survey. When we do stop this presentation, that survey will automatically pop up. But if you are not at your computer, you do need to copy that link so that you can take the test at a later time. Also, while we're waiting for questions, I also want to remind everyone that we will be doing another webinar. Well, let me back up. We're going to archive. Mrs. Holloway is going to do a face-to-face next week on identifying and responding to dementia issues during screening and assessment. So following week, we should have that archived, that if you would like to go to the RCI website, you can view that at your own time. Okay, we're ready for some questions. All right, Ms. Holloway, how would you handle toileting in inappropriate places?
That's a very good question, Joy. This is a behavior that more men exhibit than women. One thing would be to put them on a routine toileting schedule and hoping to catch them before they inappropriately toilet themselves. But even that in itself is hit and miss. One thing that we discovered in the facility was that if they were not able to get their pants down, then it would give us an opportunity to see them fiddling with their pants, and so we knew that they needed to be toileted. So we would put men in zipperless pants and belt those with belt loops and have the belt buckled in the back. Another thing that we used would be a large sign that said toilet over their toilet. That would work with some. And that's two of the solutions that we tried and found successful.
Okay, is there anyone else? Okay, well, Mrs. Holloway, we would like to thank you, and that concludes our webinar.
Thank you. Please stand by.